Okay, I will. Sorry, let me move my little control out of the way. All right, Sumi and Amber, can you guys see the slides?
Yep.
Okay, let's go ahead and start when you're ready.
All right, perfect. Thank you, Susan. Good
Yeah.
afternoon, everyone. My name is Amber Anderson, and I am an improvement specialist for the Patient-Centered Primary Care Home Program.
And I'm Sumit Singh. I'm a verification specialist with the program.
Thank you all for joining us for our webinar on PCPCH Standard 3D, Health-Related Social Needs.
I don't know why. Okay.
Thank you. First, just a few webinar and Zoom etiquette reminders. The webinar will be recorded and uploaded to the PCPCH program website. If you're having any technical difficulties, please private message Rachel Palmer for help. If you feel comfortable, please have your camera on and put your name and organization information up. As Susan said, any questions or comments you have can be put into the chat and we will answer them during the questions session at the end of the webinar. So here's the agenda for today's webinar. I'm going to start by providing a brief overview of the 2025 PCPCH recognition criteria. Next, we will deep dive into PCPCH Standard 3D. Then we will share additional PCPCH resources and upcoming webinars. And lastly, we will have some time for your questions. So the the Patient-Centered Primary Care Home Program was established in 2009 by the Oregon Legislature as part of the state's broader health system transformation strategy to improve access to care, reduce cost for patients, and improve population health. The standards are developed in partnership with an advisory committee and have been revised 5 times since 2009. The 2025 PCPCH standards were developed to support OHA's strategic goal of eliminating health inequities by 2030. The standards specifically help primary care practices build their capacity and processes to address inequities in their patient population. All practices applying or reapplying for PCPCH recognition after January 1st of 2025 must meet these new standards. For more information, I would encourage you to watch the recording of the 2025 PCPCH standards webinar, which is available on our website.
Today I'm going to review PCPCH Standard 3D, Health-Related Social Needs. This standard, 3D, is in core attribute 3, comprehensive whole person care, which from the patient's perspective means provide or help us get the healthcare information and services we need. The intent of Standard 3 is to help practices address health-related social needs, such as housing instability, transportation, food insecurity, and exposure to interpersonal violence that directly impact health outcomes. The intent of this standard is for PCPCHs to assess and, when possible, intervene in patients' health-related social needs as a part of routine wellness care. Under the 2020 model, this standard was known as Comprehensive Health Assessment and Intervention. The title was updated to clarify that 3D is focused on health-related social needs. Health-related social needs are individual-level adverse social conditions that can negatively impact a person's healthcare or health in general. Some common examples are housing instability, food insecurity, and transportation. Screening for health-related social needs as a part of routine clinical care allows PCPCHs to efficiently identify and potentially help address health-related social needs amongst the patients they serve. Standard 3D is a check all that apply standard. This means that you may attest to all of the measures that describe your practice's activities. There are 2 measures in standard 3D. The first measure is measure 3D2. PCPCH has a routine assessment to identify health-related social needs in its patient population and refers patients to community-based services. This measure is worth 10 points. The second measure is 3D3. PCPCH has a routine assessment to identify health-related social needs in its patient population and assures that patients can access an intervention for at least one health-related social need through referral tracking, collaborative partnerships, or by offering it directly. This measure is worth 15 points. Under the current 2020 model, 3D is a progressive standard with 3 measures. Practices can attest to 5, 10, or 15-point measures under the current model. In the 2025 standards, these have been consolidated into 2 measures that are now check all that apply. Practices can attest to 10, 15, or 25 points.
Thanks, Amit. So now we're going to take a deeper look into measure 3D2. A practice is meeting measure 3D2 if it routinely screens or assesses its entire patient population for at least 3 health-related social needs and refers patients with positive screens to relevant community-based resources. Practices may either conduct this screening directly or partner with external entities. The main changes to this measure is that the practice must now screen for a minimum of 3 health-related social needs and are now only required to demonstrate referrals to community-based resources. Closed-loop referrals or referral tracking will be moved to measure 3D3, which we will dive into shortly. For practices that decide to attest to this measure and screen their patients directly, we have a best practice section available in the TA guide that provides guidance around how to do this in a trauma-informed way. So here are some examples of community-based resources that practices may refer a patient to after a positive screening for health-related social needs. There's local food banks or farmers markets, community rec centers or senior centers, churches or religious organizations, and county or other public health service departments. As you're completing your PCPCH application, we strongly recommend you gather and collect all documentation that would be needed for a site visit. At a site visit, you would be required to show this documentation to the PCPCH program to demonstrate that you are meeting the measure. For measure 3D2, here are some examples of what you would need to show you are meeting the requirements. A policy, procedure, or workflow demonstrating your strategy for assessing health-related social needs of your entire patient population. We'd want to see a copy of that assessment tool or screening questions that are used. And we would want to see the policy, procedure, or workflow demonstrating the referral process to your community-based organizations.
Thanks, Amber. Now we're going to review the specifications for the second and final measure in this standard, measure 3D3. A practice is meeting measure 3D3 if it is doing all of the following. It routinely screens or assesses its entire patient population for at least 3 health-related social needs. Screening may be conducted directly by the practice or in partnership with external entities. Second, the practice analyzes data to identify target populations or the most prevalent health-related social needs amongst its patient population. I'm sorry. Did my Zoom screen freeze for a moment? I'm trying to catch up. Okay, the specifications continued. The practice offers I'm sorry, my Zoom just froze. Can you hear me? Okay, thank you. I see thumbs up, so I guess okay, my audio is fine. Third, the continuation of 3D3. Third, it engages in one or more of the following population-based interventions for at least one health-related social need identified in its patient population. It may offer direct services such as vouchers, a workshop or program, development of self-management resources, or other forms of direct support. It partners with a community-based organization or an external entity to collaboratively provide direct services, and refers its patients to health-related social needs service provider organizations and tracks those referrals to completion. That is, participates in closed-loop referrals. Referral tracking, or the term closed-loop referrals, is the process by which a practice keeps records of referrals, referral follow-up, and referral statuses. Closed-loop referral document referral information, results of these, and the outcome of said referral. So an example of 3D3. A practice screens each of its patients for health-related social needs and analyzes the results to find that many of its patients on the Oregon Health Plan are experiencing housing insecurity. In response, the practice works with the patient's CCO, which has a partnership with local housing assistant organizations. Patients with positive screen for housing insecurity are referred to the housing organization. The CCO updates the practice on the progress of the patient in receiving housing, which is then updated in the patient's chart notes. Another example of how a practice might complete 3D3. A practice screens each of its patients for health-related social needs and analyzes the results to find that many of its patients struggle with utility needs. The practice uses a closed-loop community referral system, such as Unitas, to refer its patients to utility assistance resources and track their progress in receiving assistance. Patients' charts are updated with their status, such as whether they were able to connect with the assistance and/or what remaining barriers they might be. So as at a PCPCH site visit, you would need to provide the following pieces of documentation to demonstrate that you are meeting Measure 3D3. A policy, procedure, or workflow demonstrating strategy for assessing health-related social needs of the entire patient population, an assessment tool or the screening questions that are used, data demonstrating the health-related social needs experienced by the practice's overall patient population. This can be in the forms of reports or lists, and evidence of a population-based intervention implemented in response to the patient's identified needs, such as evidence of direct health-related social needs assistance, a collaborative partnership with a community-based agency, or closed-loop referrals.
Thank you, Samit. The PCPCH program is hosting this webinar series to assist practices and other community partners in understanding the new standards. Webinars are scheduled every other Friday through December. You can find a complete list of topics and registration information on our website. The next 3 webinars are listed here on this slide. I hope you guys will be able to join us, but if not, webinars are recorded and posted on our website. This final slide is additional resources that you may find helpful. The first is our PCPCH program website. Here you can find anything PCPCH related. The second is our 2025 TA guide with detailed information about how to implement every measure and the documentation that is required. Next is a link to our TA resource webpage. And finally, the community engagement report and evaluation that was done. Lastly, you're always welcome to reach out to the PCPCH program with any questions through our program email. So that concludes our webinar on Standard 3D. Thank you so much for joining us. And it looks like we have some questions in the chat already, so we'll start going through those.
All right, so the first question is from Jessica, and it's referring to Measure 3D3, specifically the requirement that clinics analyze the HRSN data to identify the most prevalent HRSN or specific subgroups. And Jessica asks, is there a recommended time frame for analyzing the data?
I don't know that we have necessarily a recommended time frame. I think it's what's going to be useful for your clinic. Some are running it monthly and analyzing the data. Some are doing it quarterly. I mean, I think in a way that would be meaningful and useful, I would say quarterly would be a good place to start. But there is no recommended or guideline in the TA guide.
All right, and Kimber asked, would that third bullet in 3D3 include using Unitas as your referral platform? And I think Kimber's referring to the closed loop referrals. Oh, and it sounds like the last example did answer it. And yes, if you look at the example, you'll notice that in addition to using Unitas, having some way to record that closed loop process in the patient's chart notes would be one way to use Unitas to meet this measure. All right, Nicole says, clinics may have barriers in closed loop referrals depending on how they are tracking referrals. Many community resource agencies do not document in the medical record or EPIC, which is what primary care offices utilize. And yes, that is something. So one of the things in 3D3, so you'll notice that the requirement is that you're doing closed loop referrals for at least one health-related social needs. And so the idea there is that even if the community resource agencies that you're referring out to, not all of them will have a way to document that or will have like kind of a built-in system for that. But we would expect that for at least one health-related social needs that you're figuring out a way to record that information in the chart notes, whether that's tracking it yourself through an Excel or inputting the information from Unitas, but we do only expect it for one because we understand that it's unrealistic to be doing that for all of the referrals.
And I guess I would also add to that that a lot of clinics are using their referral capability in their EHR and are creating like community resource or the food bank resource or whatever it is as a referral option into their built-in system within their EHR. That's another way to track them. And we understand you can't call the food bank and ask them if Miss Smith came and got her veggies with her voucher. They're not going to keep track of that, but you can definitely call Miss Smith and ask her if she went in and used her voucher. And that's a way to close that loop. And that's a way for you to find out if she didn't go, why not? Did she have transportation issues? Let's address those. Maybe there's other things going on. So closing that loop doesn't necessarily mean reaching out to that community-based organization. It could be done by reaching out to the patient as well, and then documenting it in the chart.
Lindsay has a question. Will the outcome of the closed loop referral as resolved or unresolved / outstanding impact the metric? For example, utility assistance and rental assistance often run out and the patient has exhausted available resources, but the need remains.
Oh, I can answer that, or I don't mind answering that. That's a great question. And no, the outcome of the referral does not impact the standard or the measure itself. What we're really hoping to see with 3D health-related social needs as a standard, but definitely with 3D3, is that there's a process for addressing that one health-related social need that is outstanding, and that the clinic is making an attempt to address that need for their patient population, whatever that need may be, or whatever is most prevalent that the practice has identified. As long as there's a closed loop referral, whether you are, your process includes reaching out to the patient to see if they actually accessed in this case, if it was utility assistance, or if they weren't able to, whether the practice can actually achieve that outcome for the patient doesn't negatively impact whether you meet the measure or not. So we're really looking for that process to address these needs and also have an intervention in place. But if it doesn't occur, because we do understand that these resources are finite and practices can't be the end all be all with these types of standards and measures, it's okay as long as that closed loop referral process and intervention is in place and the attempt is made consistently with their patient population.
jumped in with some experience, saying we have been working with our CCO and EHR vendor to resolve this double entry problem. We're not there yet, but they are working on it. Thanks for that feedback, Chris. So question from Cadence, is there a way to bill OHP insurance for appointments about social wellness?
Susan, you're muted.
Thanks, Amber. I would just say that, so our program isn't, we don't have the knowledge about the ability to bill OHP or any billing services for that matter for social wellness or sort of any sort of primary care billing issues. I'm trying to think, is there a way to bill OHP insurance for appointments about social wellness? I think that would be more of a CCO related question. We don't have that information, unfortunately.
Yeah, I was gonna say, is there anyone else on the call that is familiar with this? I see Kimber just put some information into the chat.
Kimber said you can look into care management billing. That might be an option. I also know there's something called flexible services. CCOs offer that as a payment option for things related to health-related social needs, specifically referrals sometimes.
Oh, sorry, Rachel, could you see that name of that item again?
Yeah, it's called flexible services. And if you contract with a CCO, I think there's I'll put the website in, I'll put the website about it in the chat actually right now so that people can look into that. And in the meantime, Nicole says a lot of outcomes are in progress notes as text, not pullable for reports. I know in the past PCMH has looked at specific case examples during audits.
So essentially, again, the outcomes are not necessarily things that we are wanting you to run reports on. It's more of, you're routinely screening for at least 3 of those health-related social needs. And then for what you're screening, you are somehow tracking, and this is for 3D3, you're somehow tracking what is your most prevalent need amongst your patients. So how you do that can be up to you. It can be, a structured data field in an EHR where you have the 3 that you're tracking or that you're screening for, and you're marking positives that way, and that's pullable in a report. It could be, down to a lot of labor intensive work to where you have them filling out paper screeners and you're having someone, add an Excel sheet and putting positives in an Excel sheet. But one way or the other, we want to see that you are able to identify what is the most prevalent need amongst your patients. So how you choose to do that is kind of up to you. Some EHRs have that capability, some don't. And it looks like there's a question up above from Jessica about, does the referral report that we can generate through our EHR, is that acceptable? We run that monthly and go through to see who went to the offices we recommended. We also use the community resources template. And again, I think that's it depends on how you use that. If you're screening for 3 health-related social needs and you're doing referrals for all 3 of those health-related social needs, and you can somehow track that way, which is the most prevalent, then that would work. It kind of just depends on how you are documenting your screenings and your positives and your most prevalent need.
We have another question from Rhonda. Is it acceptable to record information in an Excel spreadsheet for 3D3 versus having it in a chart note? Cadence oversees this aspect of care in the clinic.
I know I'm talking a lot, but yeah, I think we still want to see it in a chart note. We still want to see that those screenings are being done and documented in the chart note. I don't think that I think that, and I'm pretty sure that's part of the documentation requirements is how you're documenting for your entire patient population, the tool that you're using to screen your population.
This is Randa here,
Huh.
the nurse practitioner.
Yeah.
So the workflow that we have in the clinic presently is during the wellness visit, I give a social needs assessment, and I'm really thrilled to give this assessment because it broadens the resources available for patients. When patients indicate that they have a need, I upload them all in documents, but then I'll let Cadence know this needs follow-up. And then she uses the United, I think it is, platform, and she takes it from there and tracks. So then it typically doesn't come back to me, so I'm not sure how to incorporate this back into my chart note.
So you would not need to incorporate like the outcome of that back into your chart note if she's like tracking that in her Excel spreadsheet.
Yeah.
She's tracking all of that in her sheet, then for, you know, like a site visit, then that would work as demonstrating that closed loop. If she's keeping all her notes on there, you know, that she reached out to the patient was able to receive services, or like I mentioned before, no patient was able to receive services, you know, and this is what we kind of did for the next steps. And that is like documented in her Excel forms. Then yeah, that would be a way that you're tracking those referrals and closing that loop.
Right, and
You
she
wouldn't have to
also,
have that in your chart note.
okay, because she will make an encounter note and track, but it's not
Yes.
literally in my SOAP note.
That's totally fine. We want to see that screening happened, like you mentioned, like you do that screening and that is documented in your chart. And you know that it's positive is essentially documented in your chart, that she was sent to Cadence, you know, who oversees those. That's, you know, in the chart note, and then Cadence takes it from there. And that's
Right.
totally acceptable.
Thank you.
Question from Demi. I'm curious if by entire patient population, you mean screening for health-related social needs at both WCCs and sick appointments?
I can go again. We, you know, we want to see that patients are being screened at least annually. A lot of times that is done at well child checks or annual well visits. But you know, if you have that kiddo who's coming in only for sick appointments, and maybe it's hard to get them in for their well child check, then yeah, we would want to see that screening being done at a sick appointment. So it's however you can get those screenings in, at least annually. Some folks can even add it to like their health maintenance tab as one of, you know, right along with the PHQ-9 or the SBIRT or any other service that's due. Some EHRs have the capability to add that right in there with it. So you could add a health-related social needs screening right in there, make it an annual process, check it when it's done, it pops back up when it's due again.
Megan asks, so long as the documentation is in the patient record, not necessarily the chart note, correct? And I'll just jump in real quick. So the documentation required for both 3D2 and 3D3, chart notes aren't referenced specifically. So I do believe we're just talking about the patient record, but I'll let the site visitors confirm.
I can take this one. So when we say chart note, that could also be a telephone encounter. That's also a type of chart note. So anywhere in the patient document, not necessarily a SOAP note. It can be in the free text field of a referral. It can be a telephone encounter anywhere in the patient record where it's associated with that specific MRN.
And Jacqueline asks, so you don't have to screen outreach to all patients. You can only do ones who are coming in. We do mention entire patient population in the specifications. How you go about doing that and what you define as your patient population is unique to your practice. But you wouldn't be able to just leave segments of your patient population out. Does that answer the question?
Yeah, I'd add to that. We're not asking clinics to do specific outreach or, call patients to be doing these screenings. It is meant for when they're in clinic. So yeah, your entire patient population, as Rachel was referring to, is we don't want you just doing this for your CCO patients and not your entire patient population. So that's what we mean when we say that.
Kimber asks, with many health systems implementing HRS and screening, patients do come to us already screened and engage with another organization in getting support. In an effort to be trauma informed and not over screen, we are trying to use our judgment about us screening them as well. Any thoughts on this? Actually, yes. So we encourage partnering with external agencies such as like CCOs or other agencies. If there is a way for you to determine that a specific patient has already been screened and to access that information, we would encourage some sort of system that allows you to do that, because we do understand the risks of screening fatigue. And if you have any suggestions or examples of how you do that, then we welcome any sort of suggestions as well.
And again, kind of adding to that, again, if you're using a CCO or somebody else to be collecting that information, we again don't want that to be the only population you're screening, thinking, oh, we're using this information. You still are wanting to be screening your entire patient population.
Yeah, and I'll just add, it's typically for us, and I tried to clarify in the chat, but because we share an EHR instance with Legacy, it's that they've already been screened in a Legacy clinic. And so where in Epic, you see this on the storyboard. And anyway, we can see the icons already being completed. And so then we're trying to use judgment about if this was just done a month ago. We're not gonna, ask them again if it looks like it was 11 months ago, or, then we might re-engage. But we were just a little unsure if there was anything else we needed to think about with that.
And that sounds great. And that's all things that could be in that written policy, procedure, or workflow. And you're demonstrating to us, why you're not actively screening all of your patients. And this is why. Oh my gosh, my phone never rings this much in a year. Sorry, guys. Okay, I'm so sorry. Again, yeah, my phone never rings. But yeah, anyhow, that can be included in your policy procedure workflow, and you can demonstrate to us how you are actively using, information from a third party and how you're still able to screen your other patients and what that kind of process looks like.
Lindsay asks, given the 1115 waiver expansions and the exciting ways to resolve needs as part of a Medicaid member's benefit plan, would OHA and the PCPCH TA team be open to spotlighting success examples between CCOs and clinics of these linkages? Additionally, would love to see OHA/HCS and CCO/clinics spotlighting how they are linking up with long-term rental assistance and recent homeless housing investments from the governor's office. And yes, we would love to spotlight examples like that, both in our program update and in future learning collaboratives. We can definitely look into some of those examples and seek those out. And we're also open to, if anyone ever wants to share some examples that they think would be helpful to all of our PCPCHs, we're happy to spotlight those types of examples. Chris says, that's part of our convo with our CCH and EHR vendor regarding two-way data flow. We all want access to this data to meet the need, but really need to be sensitive to over-screening. We need the systems to talk. I agree. That's been something that's been in discussion among us, as well as just hoping that those types of systems become more readily available in the future, just to address that issue of over-screening. And in the meantime, we just encourage whatever ways or pathways are possible to coordinate on that. And Randa asks, is it permissible to use a pre-screening questionnaire before offering the social needs assessment tool? For example, do you have any concerns with obtaining food, paying rent, living in affordable housing, getting to your medical appointment, etc.?
I think that's a great question, and I don't think that's one that we have discussed as a team. You know, you're asking one question, you're asking about multiple health-related social needs. I don't know if that would be one that you would follow up with then a second questionnaire, getting more specific. And if so, does that get into that burnout part of filling out questionnaires? So honestly, I don't know if we can provide you with an answer on the spot right now of if it would meet or if it wouldn't meet. It would be verbally asking the patient. So you'd be verbally asking that in an appointment and documenting it in the chart. And then if it was positive, you'd be tracking those. I mean, I guess it would just all kind of come down to, again, like your policy, procedure, and workflow of how you're utilizing that information, making it meaningful, making sure the patient's getting their services, and what level of the measure you're testing to. I don't know if anyone else has anything to add.
I would just add that I mean, it's certainly permissible. Like if it overall works for your practice's workflow to do that, and it leads to like an overall health related social needs screening like Prepare, or if you somehow align that data with, if you do work closely with your CCO and somehow you can reduce screening fatigue, because that's also what's part of this, the intent of this standard, in partnership. Like if you're doing 3D3, if you are partnering with an external entity, one of the goals there is to sort of reduce screening fatigue and over screening patients. So I mean, it's certainly permissible to do it, but I don't know, and this is something we will take back as a team to address and we can follow up, but I don't know if like a pre-screen would be enough to meet measure 3D3. If it makes sense for your workflow and it leads, like I said, to a more thorough health-related social needs screening that makes sense for your patient population, and your patients aren't being screened all over the place with CCOs or public health department or wherever else they're accessing care, then that should be fine. I would just be mindful of that screening trauma.
And just to add to that, because you mentioned verbally asking the patient, we do definitely encourage any approaches that you feel like are a good fit for your patient population. And in the best practice box, you'll notice that some of the examples we give are, for example, leveraging community health workers to screen. Oftentimes they know what way to approach or how to ask the questions in a way that resonates with your patient population. And so we do encourage kind of being creative in how you approach this and considering what will work best for your patients.
Okay, any other questions before we wrap up? Oh, something you've noticed.
I can't type fast enough. Don't want to keep everyone waiting. Something I've noticed is when we have received positive answers to our assessment questionnaire, that I think in multiple communications with the patients, it seems like they're not clearly communicating in advance kind of all the information that'd be helpful for us to reduce that burnout. So I'm really looking forward to seeing the OHA, like the TA guide, trauma informed section, and seeing if that helps us address some of that. But part of our workflow, we end up finding that we're trying to make things as like brief and succinct as possible, but we're noticing that we need so much more nuance actually in the conversations. And then especially when there's barriers to care that the patients are experiencing, when the referral is a closed loop. So I know, just speaking for our clinic practice, knowing how we can like afford to have extended conversations with patients to actually resolve even one of the challenges, if we're just going to focus on at least hitting a minimum of one, would be beneficial. I do feel like more often than not, we're able to connect a patient with at least something. But I would say it's at least half of the time that there are, it's a more complicated process than just a 5 or 10-minute exchange.
Hey, Rachel, my screen is frozen. Are you seeing anything else in the chat?
Yes, so Lindsay shared the Oregon Primary Care Association's list of screening and workflow tools, just as a resource for everyone. I checked it out and this looks like a really great resource. So thank you for that, Lindsay. We also, in the TA guide, have a list of OHA approved screening tools. Those aren't, they're specifically the list of tools that have been approved for CCOs. Those aren't required to meet this standard, but we just have it as a resource in case you wanted to align with CCOs in your screening tools.
Okay, if there isn't anything else in the chat, like I said, mine's frozen. I'm stuck like,
I don't see anything new.
no, okay. Okay, well, thank you everyone for the rich discussion and the participation. I feel like this was one of our best question sessions. So thank you again for being so engaged. And like we mentioned a little bit, we will take back the questions we didn't have answers for back to the team and discuss, and hopefully we can return with some sort of answer or maybe further guidance. Finally, things that you can look out for us next week is just a follow-up email with a survey highlighting your experience with us today, and then an opportunity to give us any feedback or any questions. And then we will also follow up with the slides and the recording from today. And with that, we wish you a happy sunny weekend. Thanks, everyone.